Dr. Janet Ligari is our next speaker. She is from the Department of Pediatrics at University of Wisconsin, Madison School of Medicine and Public Health. She has many publications on studies in children with achondroplasia. She's the clinical director for Bone Dysplasia Clinic, Neuromuscular Disorder Clinic, and participates in high-risk newborn follow-up clinic. It is our pleasure to have you, Dr. Ligari, give us a talk on what we have to know about achondroplasia and other skeletal dysplasias. This topic has been coming up for us quite a lot this few days and months. Thank you so much for agreeing to be our speaker.
Well, thank you for inviting me. I wish that I was there in person. What I'd like to do is really go back and make sure I'm going to go through some of the most common skeletal dysplasias, and then we're going to end with achondroplasia. So I have a lot to cover in a fairly short amount of time. So I do need to say that I am on the speakers faculty for BioMarin Pharmaceuticals. I also receive funding for research on the achondroplasia natural history study from BioMarin Pharmaceuticals. I am specifically not involved in their clinical trials, and I think that's important to know. I am a site PI on another clinical trial for achondroplasia that is sponsored by Ascendis Pharma. So our objectives today are to review normal proportions and growth. I know that you guys are endocrinologists who know this stuff, but I'm just going to make a quick review in relation to skeletal dysplasia. We're going to learn what proportions are most concerning for skeletal dysplasia, review signs of suggestive of a positive skeletal dysplasia that aren't necessarily just bones. Review the most common short-limbed, long trunk dysplasias. I put in a lot of pictures because many of you may not have seen patients with these diagnoses. And also I'm going to talk about short-trunked, long-limbed dysplasias. And then we're going to focus on achondroplasia in the last part of the talk in the new medication approved to help increase annualized growth velocity. So as you guys know, body proportions change over time. Babies are born with big heads, relatively long trunks, relatively short extremities compared to their trunks and their heads, but this really changes as they grow. For example, in babies, their mid-height is about their midpoint is 1.8 centimeters above the belly button. But in an adult, it's at the symphysis pubis, so at the bottom of the pelvis. Now, interestingly, in adults with achondroplasia, their midpoint is 1.8 centimeters above their umbilicus usually. So they have a lot of proportions very similar to infants. Their sitting height in babies, your sitting height is about 70% of your overall height. But again, by the time you've reached adulthood, it's about 53%. So this is just a reminder that our heads take up a lot more of our overall height proportion when we're born. It's even, it's 25%. And this eventually decreases to 12.5%, so 1/8. And so many people with skeletal dysplasia may have normal size heads, but shorter overall bodies, or even larger heads for their short bodies compared to average height. And so really we're looking at proportions. For normal progression of body proportions, again, extremities are shorter, but by about 10 to 11 years of age, your wingspan should be about the same as your height. Our head again becomes a smaller proportion of our overall body height as we grow. Our upper to lower ratio, so again, measuring from the symphysis pubis to the feet, and then the top of the head to the symphysis pubis, should be about 1.0 by 11 years of age. It might be a little bit later if you're a late bloomer. But I don't know if you guys have been sitting a long time in the lecture halls, but if you could all stand up and put your arms down and see how far they fall down your thighs. They should fall about a third to a halfway down your thighs. That is normal. The other thing that's normal is if we look, you can all sit down. If we look at our arms and legs, our proximal segments, so our humerus, our femur, is longer than our mesial segment, which is our forearms, our tibiae, which is longer than our hands and our feet. So when we see these proportions are different, that strikes us as disproportionate. The definition of disproportionate is actually when you have some segments of the body that are normal size or normal growth, and some segments that are not, that are shorter or longer. So as we're talking about these skeletal dysplasias, it's important to understand some terms. Micromelia means overall shortening of the extremity. Rhizomelia means the proximal bones shortening. So again, your femurs, your humeri. Mesomelia means your forearms or your shin bones. Acromelia means your hands and your feet. Short trunked means that your arms and your legs are relatively long compared to your trunk. Long trunked means that your trunk is average size, but your arms and your legs are short. So bone age. I think it's important when we talk about bone age because this is a tool that is used a lot by pediatric endocrinologists. Unfortunately, if a patient has a skeletal dysplasia, it is notoriously not accurate. And I think it's an important concept to know. So if we look at the bottom, this picture, you'll see how the bones form. We have throughout embryology, then you get an ossification center, and then the secondary ossification centers are in what we call the epiphyses. The growth plate is in between the primary ossification center in the diaphysis of the bone and the ossification center at the end of the bone, the epiphysis. So what we're measuring in a bone age is actually the ossification of the epiphyses of the radius, the ulna, the carpal bones, the metacarpals, and the phalanges. So as you can imagine, if you have a problem with your epiphyses, you're obviously not going to have an accurate bone age. So epiphyseal dysplasias, so those that affect the ends of the bones, those epiphyses come in late. Bone ages are somewhat accurate when it comes to other types of bone dysplasia, like metaphyseal dysplasias. So I'm just going to, again, show some pictures so you get an idea of what we're looking at. So these are all long trunk, short extremity dysplasias, and these are babies at birth. Average stature is on the right, so you get an idea. So now the most severe is on the left. That's called thanatophoric dysplasia. That is really a life-limiting condition. The ribs are actually considered long bones. And when they are really short, so when you have severely short arms and legs, your ribs are also severely short. And your lungs can't grow enough to support life. So the two in the middle are achondroplasia. Babies have achondroplasia. It affects all ethnicities equally. So I wanted to show both. And you can tell that their legs are a little bit, and arms are shorter, especially compared to the average stature baby on the right. But many people don't see it initially unless you have an average stature baby right next to them. So we're going to go through the most common ones. Again, I'm going to finish with achondroplasia. So we're going to go through pseudoachondroplasia, hypochondroplasia, Leri-Weill Dyschondrosteosis, Turner syndrome, and Diastrophic Dysplasia. The big hallmark of all of these is that their wingspan is shorter than their height. Now that's after age 10 or 11. There's a book that has all of the normal values for when what your wingspan should be at certain ages and the ratio with your height. And so what we're looking at is their wingspan is always shorter. So pseudoachondroplasia, this is actually an epiphyseal dysplasia. So the ones at the end of the bones. What's unique about this diagnosis is that these kids actually start out growing normally. They start growing normally along the curve, and then they fall off the curve by about 18 months old. They have very specific skeletal findings that we see. They have a pathogenic variant in the cartilage oligomeric matrix protein, which helps hyaline cartilage grow and epiphyseal ossification. So these kids, it's called pseudoachondroplasia, even though it's not the same gene, because they look a lot like achondroplasia. These people have elbow flexion contractures. You can look at these pictures, and he's got short extremities. Look at where his extremities fall. They fall just at his iliac crests. They have normal head sizes for their age. So relative to their height, it looks like their heads are big, but really their head is completely normal size for their age. And there's a lot of increased laxity with these kids. So they have difficulty holding pencils and markers. These are the kids that can do the horizontal splits. You can see his legs this is what we call windswept. You have bowing on one side and knock kneed on the other. And they have a swayback or a lordosis. Again, this is autosomal dominant. It affects all ethnicities. The next one is hypochondroplasia. So this is caused by a pathogenic variant or a mutation in fibroblast growth factor receptor 3. This is the same gene that causes achondroplasia, but it's a different location in the gene. So it's some literature says that about 10 to 15% of people who present to pediatric endocrinology with idiopathic short stature have some type of skeletal dysplasia. So when you look at these kids, this is one family, I believe, and look at where the arms again fall compared to the thighs. They all have relatively short extremities. Their heads are slightly large for their age. But many times hypochondroplasia is not picked up until later in life. There are less medical consequences than achondroplasia, but they get more cognitive challenges. In general, skeletal dysplasia does not affect your cognition. But hypochondroplasia is one of the exceptions. Leri-Weill Dyschondrosteosis. Most of you have probably seen a case of this at some time. So this is caused by a mutation in the short homeobox of X gene or SHOX. And this, you have a lot of mesomelia, so really short forearms or bowing. And one article I read, this accounts for 10% itself of idiopathic short stature, which is quite remarkable. Again, you can have curving of the forearms. If you look at the pictures here, the Madelung deformity is actually when the forearm and the carpal bones are in a different plane. So you get a step off. You also can get some V'ing of the carpal bones. And so if you're doing a bone age and you see, and you're seeing that the radius and the ulna, where they meet the carpal bones, forms a V, that can be a sign that, hey, maybe there's a skeletal dysplasia here. That's caused by a Vickers ligament, which is actually an extra ligament that attaches from the carpal bones to the forearm. Again, you can look at these pictures and see that the arms are short. They hit the top of the thighs. You can see downward slanting of the medial tibial plateaus. So again, there are very specific X-ray findings that we see with different diagnoses. But if you see somebody come in and their head circumference is normal for their age on the chart, their wingspan again is shorter than their height, and proportionately it looks like, hey, they have some shortening of their forearms, that's kind of a red flag. There are certain standards. So if you get an X-ray that has all of the upper arm in one film, you can do ratios. And we have sets of ratios that are normal and that are concerning. So Turner syndrome, you guys have all seen Turner syndrome caused by one copy of the X chromosome. Again, you see the same skeletal findings that you do in Leri-Weill Dyschondrosteosis. And the reason is because the skeletal findings in Turner syndrome arise because of that missing SHOX gene. Used to be that if you saw a Madelung deformity, and here's another sample of that, you automatically thought Turner syndrome. But now we also know that Leri-Weill Dyschondrosteosis is extremely common. So diastrophic dysplasia is autosomal recessive. All of those other ones we were talking about are autosomal dominant, except for Turner syndrome. So diastrophic dysplasia is caused by pathogenic variants in the gene DTDST. And these are, these kids have normal size heads, but very short arms and legs, long trunks. One of the pathognomonic features of this diagnosis is displaced thumbs and great toes. So you can see that picture of the thumb. And if you see a baby with that, with short fingers, you usually think diastrophic dysplasia. Again, short arms and legs. And this is one of the few that is autosomal recessive again. So it's a surprise for parents frequently when their babies are diagnosed, or if it comes up prenatally. This picture below, you can see the girl in the red is average stature. Her two younger sisters have diastrophic dysplasia. And you can see, if you can see on the hand right here, oops, sorry, you can see her thumb displacement. So now we're going to move on to short trunked skeletal dysplasia versus normal. So if you look at the baby on the left, the baby has a short trunk, but also short arms and legs. So except for having a relatively large head, looks fairly proportional. But then look at the, again, compared to the baby that's average stature on the right, you can see that everything's just compact. So short trunked, long extremity dysplasias, I'm only going to cover three. Spondyloepiphyseal dysplasia congenita. We're going to talk about type 2 collagenopathies and then multiple epiphyseal dysplasia. And I have received referrals from our pediatric endocrinologists for all of these. SEDC, or spondyloepiphyseal dysplasia congenita, is usually diagnosed much before they would get to see you, or before they would see you, because it's usually found at birth. These children tend to be born with very short trunks, but also short extremities. It's caused by a problem with type 2 collagen, which is really important in making the ends of the bones, and again, the hyaline cartilage that is important in joints. Now, type 2 collagen is also very important in the eye. So these people tend to present with myopia and what we call high myopia, which is severe nearsightedness. They also, as they grow, their proportions change. So as they grow, their arms and their legs grow more than their trunk. And thus they end up having relatively long extremities compared to their trunk. So if you look at the picture of this girl, you can see that her fingers reach all the way to her knees. And she's only about 7. You can also see a pretty significant lordosis. And that arises because there's a lot of hip issues and what we call a waddling gait. So they actually sway back and forth when they walk. This diagnosis, you can also see club feet. You can see cleft palates. Again, because it affects the ends of the bones and that ossification, bone ages are not accurate. Now, all type 2 abnormalities do not cause SEDC. There's actually a wide spectrum. And we see some people with fairly mild type 2 collagen, that could be MED that we're going to talk about in the next slide. And then there's a whole spectrum in between. So you might be seeing a child who's 7, 8, or 9, who is short statured, average normal head growth. They've always been told that they're a little heavy. Their weight for length is elevated because they're short. And their arms are relatively long compared to where they should be at their age. So again, they might present with eye abnormalities. They could also have hearing issues. So if you see somebody come in who is short statured, they have joint pain, and they are nearsighted, that might say, I think maybe I should get my genetics colleagues involved. And then the last one in the long trunked category is multiple epiphyseal dysplasia. This is where you have multiple epiphyses, so the ends of the bones again, that are affected throughout the body. This is related to short stature, but not dwarfing. And so, for instance, I follow a boy whose predicted adult height would be about 6'2", and he's 5'7". So it's not that he's dwarfed, but he is short for his predicted height. And he's actually undergoing hip replacements in a few months, and he's 15. So these kids, again, they will have a very long wingspan compared to their height. There are many causes for this diagnosis, one of which is type 2 collagen, but there are, it really ranges. So we can do genetic testing, but about 30 to 40% of the time, we never find the molecular etiology. That may change in the near future or in the far future. So again, their epiphyses ossify late, and so bone ages are not going to be accurate. So just to review, when should you think about a skeletal dysplasia if a patient is coming in with short stature? Well, the big thing to take away is if they're disproportionate. You know, if their OFC and their height are on vastly different growth charts. So if their wingspan and their height are not where they should be. If you see vision issues, if you see hearing issues, skeletal dysplasias affect bones, so they can affect the bones in the middle ear, so you can see hearing issues. If you see joint replacements under the age of 50 in the family, if the teeth aren't developing normally, as you know, teeth and bones tend to develop together. And if we see babies that have missing neonatal teeth, if their teeth come in late, if they don't lose their teeth, if they have enamel issues, that can be a sign that there's other issues with the bones, especially like metabolic bone disease. If we see blue sclera, so the whites of the eyes are very blue, that can be a sign that there's a collagen issue. And if we see club feet or cleft palates, again, those are things that you should say, maybe there's another reason for this short stature. So let's talk about achondroplasia. This is the most common form of disproportionate dwarfism. You guys, I'm sure, have been learning all about vosoritide. So this has an incidence of about 1 in 25 to 1 in 30,000. It is the most common, again, cause of dwarfing, short stature. With the current world population, that means between 250 and 300,000 people are affected worldwide. It's about 15,000 in North America. By far, the majority of people with achondroplasia are born to average stature parents. So that's a significant amount. It's autosomal dominant. It's also caused by changes in the fibroblast growth factor receptor 3 gene. And that's involved with bones that grow through cartilage, so endochondral bone growth. The health consequences that we see are because of which bones are affected. So this is a clinic, a little girl with achondroplasia. She's about 3 or 4. And so what do you notice with her? She's short. She has frontal bossing, mid-face hypoplasia. So her face is not only short vertically, but also it's less developed anteriorly. So that's what we call mid-face hypoplasia. She has a depressed nasal bridge, a short nasal spine, a little bit of nasal anteversion. Her arms are short. Look at where her arms finish or end. She has bowing of her legs and a little bit smaller chest. So what do we see with achondroplasia? We can see foramen magnum and upper cervical spine stenosis, and that's because the base of the foramen magnum actually grows through cartilage, the base of the skull. But we can also see hydrocephalus, restrictive lung disease because their lungs are slightly smaller, obstructive sleep apnea because this affects the bones. Tonsils and adenoids are normal size. We see a lot of ear issues because the ears don't drain well to the nose. We can see musculoskeletal differences, so bowing. So as you know, as an endocrinologist, you always want to use the appropriate growth charts because growth is a marker of health. I included this slide really just to show you how the upper to lower segment ratios are different in a child with achondroplasia versus an adult. So these people are about -4 to -5 standard deviations below the mean on the average stature growth chart. But by adults, they're -5 to -6. And that's because there's a negligible growth spurt. These are just some curves, an example of the achondroplasia girls curve. So why do we see all of these issues? The gene change in fibroblast growth factor receptor 3 affects it, makes it constitutively active. And what that does is it activates through tyrosine kinase a cascade of events in chondrocytes, which are cells that make cartilage. So in essence, FGFR3 actually slows bone growth in bones that grow through cartilage. It slows the division of those cells, and it slows the growth of those cells and increases the programmed cell death, the apoptosis. But this is all balanced with another process in our body that works through cyclic natriuretic peptide. And our body makes this. And that works, again, through this cascade in the cell that then blocks a lot of the actions that FGFR3 is doing. So FGFR3 and CNP in most of us are a balancing act so that we don't end up to be 8 feet tall, we don't end up being 2 feet tall. But what happens with achondroplasia is that the FGFR3 is really, really active and it overpowers the CNP. So vosoritide or Voxzogo, as it's branded, actually is a CNP analog. And it's activating that CNP pathway to try to keep up with the FGFR3. It was approved, it's a subcutaneous injection once a day. It was approved by the FDA November 19th, so very recently, but approved in children 5 years and up with open growth plates. In Europe, it was approved for 2 years and up. It was on an accelerated approval So it's approved only for increasing annualized growth velocity. What all of us hope is that if we see more growth in height, then that really means that we're seeing more growth in other bones as well. So again, we're using height as the metric, but health is the goal. So this is some information on the study, and it increased daily injections of vosoritide on average increased annualized growth velocity by 1.57 centimeters per year. And that lasted for 2 years. Again, ongoing data is being collected and more information will be coming out. But if you give a child, 10 years of Voxzogo, you may get, 15 centimeters. So the effects of Voxzogo, again, you see increased annualized growth velocity. The most common side effects were injection related, but the most notable side effect was really hypotension, but that could be mitigated by eating and drinking before getting the shot. And noteworthy is that nobody actually dropped out of the study because of hypotension side effects. So I just wanted to briefly say what other strategies are out there in development. And so vosoritide is the one up here with the green, but then Transcon CNP is also using that same method. It's using CNP, but it's in a depot, it's putting it on a depot protein, so it's a once a week injection. Those studies are in phase 2. Phase 3 has yet to be started. There's also soluble FGFR receptors, so that they bind the FGF that's floating around so that it doesn't activate that abnormal receptor or that overactive receptor. And then lastly, there's another one that's inhibiting the tyrosine kinase, so just inhibiting the receptor as a whole. So Transcon CNP, again, it's very similar to vosoritide. It's a weekly injection, and they're still doing phase 2 trials. The tyrosine kinase inhibitors, this is an oral medication, and it's called infigratinib. It's actually been around because it's used to treat cholangiocarcinomas. And there was a lot of side effects in skeletal overgrowth, which made them think, maybe we should look at it for some dwarfing disorders. We're using it at much lower doses. They are also in a natural history study phase and enrolling for phase 2. So that will be an oral medication. This is some information on mice with that. Wild type is on the left. On the right, you'll see that giving this tyrosine kinase inhibitor really did increase bone growth. And lastly, Recifercept is the soluble FGFR3. It's floating around trying to bind up all of this fibroblast growth factor, so it doesn't bind to the overactive one made by the pathogenic variant. So this is actually an injection, and they're also enrolling phase 2 studies. So if we look at mice data in that, wild type again is on the left, and when they gave the Recifercept, it did normalize some growth in longer bones. So I may have gone over time. I'm sorry that we started a little late too. Just remember that anything is possible, even with skeletal dysplasia. I always like to finish with seeing some people be really successful. So questions? You can just put them directly in the chat. Or let me look at
Thank you very much, Dr. Legare, for the excellent presentation. There is one question in the chat.
Okay, I don't see it. Can you read it?
Actually, it's not a question. Sorry. Any questions from anyone in the room?
Just a comment. I think what she's referring to is Judith Paul's physical measurements book, which is currently available in a second edition.
Dr. Gibson just made a comment that the book that is referred by Dr. Ligari in her presentation is a book on physical measurements, is by Judith Hall. Dr. Gibson, you said it's available?
Yes, it is.
Okay.
Yes, thank you. It's at my office, and I didn't know who wrote it, but I use that book frequently.
So do I. You will use that treatment in
Could you repeat that, please?
You will use that treatment in hypochondroplasia as well?
The question is, can we use that treatment in hypochondroplasia as well?
You know, that's a very good question. There are some ongoing studies, I believe that. So ultimately, the answer would be theoretically yes, but it's not approved for that. Currently, it's only approved for achondroplasia and in patients 5 years and up with open growth plates. But the hope is that with hypochondroplasia, they may get benefit from it as well. Only about 70% of patients with hypochondroplasia have mutations in FGFR3. So I think that if they have an FGFR3 mutation, I don't see why it wouldn't work.
Dr. Ligari, I have a question for you. How about treatment for SEDs, Spondyloepiphyseal Dysplasia? Knowing the mechanism of action of all the other of the drugs, would there be a candidate drug?
Currently, no. No, I think, you know, these are really not going to affect the mechanism by which that works. They are looking at some for pseudoachondroplasia. They were shown that you can preserve some of the issues with pseudoachondroplasia with resveratrol and ibuprofen, but that can molecularly, we know it helps with mice, but they're just doing some initial studies and phase 1 in adults, and they're not enrolling for phase 2 yet. But for SEDC, there's nothing that we know of on the horizon.
And for achondroplasia, what was the gain in height on the treatment?
So vosoritide average annualized growth velocity increase was 1.57 centimeters per year. Now, with achondroplasia, they usually grow about 4 centimeters per year, whereas with average stature, kids grow about 6 centimeters per year. So it doesn't quite bring them up to average stature, but, you know, we have some people who probably will respond better than others. You know, we're just going to have to see what happens as more and more people are treated.